Dear colleagues and friends, first of all, I'd like to thank the organizing committee for this kind invitation to this very interesting meeting. And my presentation, this is the title, Severe Pulmonary Valve Stenosis with Severe Tricuspid Regurgitation. You always need to tackle the tricuspid valve. It's actually a case report. We know already from Rao, who reported a lot of cases with critical and severe pulmonary valve stenosis, that this disease with intact ventricular septum results in suprasystemic right ventricular systolic pressure, often resulting in tricuspid insufficiency. Now, my patient, male, 7-month-old, with a body weight of 6.6 kilo and 65 centimeter height, came to our clinic and was discovered by chance to have a systolic murmur. Interestingly, the patient did quite well in growth, but had always a low saturation, which remained unnoticed to the parent. They thought he's asymptomatic. Now, after clinical examination, the first echo study showed this. There is a right to left shunt at PFO level. And this is here the pulmonary valve, and you see doming valve with minimal flow across it, another view. And the gradient across the pulmonary valve was reaching 180 millimeter mercury. The effective orifice 2 millimeter only. Now, looking in the four-chamber view at the tricuspid valve, there is a severe tricuspid valve regurgitation with dilated right atrium, and the gradient across the tricuspid valve was 150 millimeter mercury. The arch was normal and no sign for PA. The patient was taken next day to balloon dilatation, and this is the angio in the RV showing severe tricuspid regurgitation, and the pulmonary valve was seen here and was showed an annulus of 8 millimeter. A 10 millimeter crystal balloon was chosen to balloon dilate at a 3 centimeter length, as we didn't have a 2 centimeter length available. This is here the inflated balloon. Now, second echo study was done 1 day after balloon dilatation, and we see in the short axis view some PI and some increase into the pulmonary artery. Another view in the subcostal view, same finding, and now the gradient across the pulmonary valve is only 33 millimeter mercury with mild PI. Now, in the long axis view, we've seen here the tricuspid valve, and we see only now minimal or trivial regurgitation. Just to remind you, the echo before the cath with severe TR, and this is the echo after balloon dilatation. Now, I chose one study with 616 patients with pulmonary atresia intact ventricular septum who underwent during this long period 3 different management scenarios: aortopulmonary shunt, right ventricular decompression, or both, and not much mention about the grade of the tricuspid regurgitation. And I found out that papers dealing with infants with severe pulmonary stenosis, that many authors do not focus a lot on severity of tricuspid valve regurgitation, and the senior will know that there is this relation, and that the tricuspid regurgitation often regresses after a balloon valvoplasty. This is a paper in adult patients, and out of the 90 adults, severe tricuspid regurgitation was available in 7 patients, which regressed after successful balloon dilatation, but it took them few years. And they suggested balloon dilatation pulmonary valve should be considered even in the presence of severe tricuspid regurgitation. So the take-home message, not very interesting, but still it's highlighted that severe tricuspid regurgitation in critical pulmonary valve stenosis can improve significantly immediately after balloon dilatation of the pulmonary valve stenosis. Thank you.